Hello, everyone, and thank you for attending today's webinar. Before we begin, we wanted to cover a few housekeeping items. At the bottom of your screen are multiple application engagement tools you can use. All the engagement tools are resizable and movable, so feel free to move them around to get the most out of your desktop space. You can expand your slide area or maximize it to full screen by clicking on the arrows in the top right corner. If you have any questions during the webcast, you can submit them through the Q&A engagement tool. We will try to answer these during the webcast, but if a fuller answer is needed or we run out of time, it will be answered later via email. Please know we do capture all questions. At the left side of your screen, you will find a list of resources related to the webinar. We encourage you to download any resources or links that you might find useful. For the best viewing experience, we recommend using a wide internet connection and closing any programs or browser sessions running in the background that could cause issues. Webinars are bandwidth intensive, so closing any unnecessary browser tabs will help conserve your bandwidth. A recording of the webinar will be shared with the registrants approximately 2 days after the event. I hand it over now to the Dr. Professor Agneta Trollis-Rubin. Thank you.
Welcome, everyone, and thank you so much, Candela, for inviting me to talk about how I treat scarring of different sorts. It was important for all of us to sit down and think, how are we doing, how good are we, and what is latest news? And with us today, we have a very good speakers. Among all, Dr. Didac Barco, dermatologist from Barcelona. He holds a master's degree in aesthetic dermatology in the University of Alcalá de Henares and in lasers and photomedicine in Catalonia. And he teaches at Alcalá de Henares in Madrid, and as well as in Valencia, and both for masters and main teacher for fundamentals laser course in Barcelona. Very well experienced. And then we have, well known for all of us, Hugh Cartier, doctor in dermatology as well. He graduated at the European School of Phlebology at the Saint-Jean Derm Clinic in Arras Hospital in France. He's a global scientific coordinator at IMCAS. He's doing a lot of very good work for us there. He's also a vice president of the French Society of Aesthetic Medicine and former president of the French Laser Group. And third, André Martin, a plastic surgeon who is the owner and medical director of Clinica Medispa from Cluj-Napoca in Romania. And he undertook his training of plastic surgery in Bucharest and is performing plastic surgery and aesthetic surgery of all types, and been working with EBD since 2009. So you see, all of us have a long experience that we are happy to share with you. So please come with your questions, because that's the main thing, that you get, that we can have a discussion, intervention. So I will start because I was told to do classifications. So I will do it a little bit generalized. And I have to remind you, please do not take pictures and videos, because many of our patients, although you think it's just a piece of the face, they may recognize themselves and can get upset. Even a baby I had a picture of, and she was grown up. She told me she was upset that I have shown her as a baby. So we ask you to not to take pictures and videos. You have 2 more days to look at the talks. My background, I've been crazy about laser since the 80s. And I am the head of Laser and Vascular Anomaly Center at University Hospital in Malmö. And since 87, I've done a lot of different kinds of laser. I was so fascinated about the light, and that's just been such an interesting, fascinating road. And it's developing still. Since 1990, pulse dye laser, mainly of vascular, since 89, cosmetic also, and 96 IPL. So now let's go on. Healing the visible and invisible scars. Both of them are extremely important for our patients. And as a physician, that's what we have to cover. What are cutaneous scars? aberrant wound healing that alters the level of collagen in dermis. Here is in histology, dense chronic inflammation, void of elastic fibers, all adnexa destroyed. This is a book I highly recommend if you're interested on looking into scars from all different kind of aspects. Very good book. Scar healing mechanism, very complex and not fully understood. We have the inflammatory step after wound, proliferation and maturation. And the myofibroblasts play a major role during granulation tissue formation, with transforming growth factor beta-1 being the main soluble factor involved in myofibroblastic differentiation. And these myofibroblasts are very sensitive to mechanical environmental. Lasers are for potentially modified wound healing. During the inflammatory response, you have heat shock proteins you have to think about, matrix metalloproteinase, tissue growth factors, fibroblast affection, and neocollagenesis, distribution of collagen towards normal architecture. There are many scar assessment scales, so it's difficult to evaluate your response. And it's important to evaluate the effectiveness of scar treatment and to monitor patients over time. And traditional scar scales are clinician and researcher reported, focusing on the appearance and physical characteristics of the scar, while more recently, it points out the aspects of quality of life. And that's the main thing, isn't it? And there is an international scar classification, 2019, from Thomas Moreau, from this book. And here they divide, which I think is a very good classification, in immature, mature, atrophic, linear hypertrophic, widespread hypertrophic, and keloid. If we start with the immature, they are pink, slightly raised, sometimes a little itchy, firm but not hard, and begins soon after injury and months to resolve. And it has a peak a few weeks after injury. And the treatment is silicone gel or plasters, manual massage, compression, Botox, IPL, PDL, prophylaxis. Laser treatment of wound healing may induce a shift towards a regenerating process as in fetal life, preventing scarring on tricky anatomic areas. Start suture day, important to do before scarring. And Kevin Nouri from Miami has done many very good studies looking into pulse dye laser to prevent scarring. You may also use intense pulse light or repetitive non-ablative fractional lasers. Pulse dye lasers have been used since 1990. Excellent quality and good machine, selective absorption of oxyhemoglobin, and there are newer versions of the machine. This image you have to know if you work with lasers. This is, I call it my Bible. You have to know the wavelength and the different chromophores and the absorptions, pros and cons. Otherwise, you shouldn't work with lasers. Already, after one treatment with pulse dye laser or IPL, the patients usually report less tight feeling or less uncomfortable feeling. Pulse dye laser, the main target are cutaneous vessels that are coagulated by irradiation. A minimum once per month can reduce symptoms like pruritus and erythema and pain, but not on scars more than 1 centimeter, and more dangerous for PIH on darker skin types. And use it in combination with other treatment modalities to achieve the most effective treatment. Low risk and side effect profile makes it very valuable. This one is fractional CO2, but IPL and PDL can reduce the redness after fractional CO2. And here is a chart over the wavelengths of nodeless handpieces, the cutoff filters, the different kind of wavelengths that we are using. One clinical case after one IPL treatment. Then we come to atrophic scars. They are depressed or thinned as it transitions from an immature scar. And when collagen synthesis is depressed, and inflammation is less than usual, like stretch marks and stria that usually comes after systemic steroid excess or pushing. Then we have the different acne scars, the ice pick. They are tricky and difficult, so never ever promise the patient that this will go away, at least not in my hands. The rolling scars, better result, as well as the box scars. And when you do non-ablative fractional, stretch the skin while treating and treat across different ways, 4 different ways. Dr. Wong reported at EADV in Paris clear improvement with atrophic acne scars after 3 treatments with NAF. It's not fully gone, but it is improved, and that is my experience as well. And they don't have the side effects like we had on the fractionated CO2. So non-ablative fractional lasers, there is no disruption of stratum corneum, rapid reepithelialization, and may induce a beneficial wound healing response due to modulation of heat shock proteins, TGF, and MMPs. I mean, these are the techniques we are using: resurfacing, non-ablative, and non-ablative fractional, and ablative fractional. It all depends on what machine you have and what scar you're going to treat. And use high energy, and several treatment is needed. Here is one case, acne scarring, and this is already after 1 fractional CO2 6 years ago. And here you will show after 2 non-ablative fractional. So it's clearly a very good machine with so little side effects. Another one, acne scarring, and this is after, usually combined with intense pulse light and non-ablative. On the other side, you can treat when they are eating isotretinoin as well. This is after 1 IPL and isotretinoin and non-ablative fractional. So usually before we waited, but now we are using it actually. This is an old scarring, old acne scarring, and a weight loss. And these are some improvement after intense pulse light and non-ablative fractional. If you have an atrophic scarring like this, you need to work on the borders with CO2 or erbium vaporization, but probably non-ablative would work as well. Hypertrophic scars, here my first choice is non-ablative, 1550, at least 3 times. I don't start unless they can accept 3 times, but usually the women says, I don't need so much makeup anymore, it's easier to cover. And they are very happy to not have these side effects as we had before with the fractionated CO2. That stays for 4 days, 4 or 5 days. And if it is in the face, could be quite disturbing. So usually the patient doesn't come back to do these treatments. And here, this is to demonstrate the non-ablative on the neck. Doesn't seem to work though. Okay, I hope the others will show. And this is the window, optical window, 1550 nanometer, and that is absorption of the water. Yeah, here it is. Here comes the video. Can you see it? Good. Painful on the neck. This is a motor car accident with metal paint after, let me see, that's gone. There. After 11 Q-switch YAG laser and CO2 of the scarring. Now we come to the mature flat scars. They are the most tricky ones, and there are many young people who have been putting a knife on their arms, artifacts, and want to get rid of them. They have no erythema, and they are stable and no symptoms. These are very difficult to improve. Prevention is very difficult. Silicone on gel, if you know it's a tricky area, compression, PDL, low risk and side effect profile, makes it valuable alternative for the prevention of scars. And long-term outcome and high-quality intervention studies are necessary to provide proper evidence for PDL and application in hypertrophic scars and keloids. So with the vascular lasers, it causes less vascular perfusion. With the diode laser induces long-lasting heat shock proteins, and we get normalization of the collagen and realignment of abnormal collagen fiber. And that is caused by stimulation of growth factors and cytokines, and upregulation of heat shock proteins, inhibition of TGF, and stimulation of MMP. So these are hypertrophic linear scars. They are ropey, elevated, pink or red, evolves from immature scars with several weeks. They have a progressive enlargement for months before slow decrease in activity, often itchy and slightly sore to touch. And resolution results in persistently elevated scar that is no longer pink. These are scarring after pyoderma gangrenosum. And this is after treatment with, actually this old picture from fractionated CO2. But I think here non-ablative would work fine without wound. This is our crypts that can be tricky to vaporize, but it's possible. Then I use the continuous waves on the very thick lesions, and then I combine it. Hypertrophic wide scars. They are elevated, they are pink or red, they arise from widespread injuries such as a burn, and they're frequently severe pruritus, and they can be tender. Very stiff with limitation of mobility across joint surfaces, and that's why we need to treat to get a better mobility of the joints. Produce increased amounts of collagen per cell compared with normal fibroblasts. Here it is after treatment. It was painful here, and here the pain has gone away. Treatment of hypertrophic and keloids. Then you can use all this list: corticosteroid injections, IPL, PDL, non-ablative, YAG laser, you get deeper penetration, and debulking, picoseconds, contact or lesional cryosurgery, low-dose 5-FU, autolog fat injections. There are many roads to Rome. What we did here, this young lady had a severe accident. It was itching and hard afterwards and disturbing, and she couldn't wear her trousers. The leaning was really making her life miserable and preventing her to live her life and forget about the accident. And only after a couple of steroid injection, erbium vaporization, PDL, IPL, great improvement. And you know, my experience is as long as you do something, they feel very comforting in that, and then they can maybe psychologically work with the trauma that had caused the scarring. But we have to do something. Never ever tell them we can't do it. This is a study of hypertrophic scars, PDL in combination with fractional CO2, better than PDL alone in this study. Self-destructive behavior. I see quite a lot of these young people. And it's especially with them, I think it's important. Although these types of scars, it's hard to improve the hyperpigmentation and the lines. But please try at least 2 times. And you may erbium vaporize of the hypertrophic lesions and injects of steroids and intensifies light and non-ablative fractional for psychosocial reasons. Then they move on with their life. Thick hypertrophic scars and keloids, first debulking, CO2 erbium, steroids, then PDL, IPL, and silicone, or non-ablative. Non-ablative fractional laser, overall improvement in scar texture after 4 treatments. Here in this article, 2 weeks apart compared to the non-treated part in this split scar study. And we know, like I told you, the response is mediated by heat shock protein, fibroblast proliferation, and consequent neocollagenesis. And this one we had, so I go on. And corticosteroids why do we use them? They inhibit fibroblast growth proliferation and collagen synthesis. And we use triamcinolone, 40 milligram, if it's very thick and hard. Smaller gauge needle and syringe allows better control and minimize discomfort. And you can combine it with cryotherapy to get optimal penetration. Otherwise, you get a shower of the cortisone on yourself. When you have minor keloids, they are round or elevated, and they extend beyond scar. Often comes at the earlobe, pierced earrings or surgical incision, and it has a strong genetic component. And if you just do simple surgery, the recurrence is very high. But through years, I noticed that if I do debulking and inject steroids and IPL and PDL to prevent recurrence, we may at least flatten them and make them not so itchy and not so sensitive towards clothing. And the redness comes after steroids. Here we have the erbium absorption curve of water. I think it's erbium 12 times better absorption of water than CO2. And I use it mainly when I don't need the coagulation so much and I want to do finer work. And we show here the wavelength, 2064, and by water. If you have a major keloid like this on your sternum, they usually get butterfly shape, often irregular, and they can come after only a small, tiny acne lesion. They have multiple locations, and it's debilitating in and pruritus. And treatment options are limited. These are the biggest challenge, I think. I usually combine NAF, non-ablative, with intense pulse light because of the redness that has come after the cortisone injections. This lady had itching keloids around her breast after breast reduction caused by traction after removing the nipples. And here she is after 3 IPL, corticosteroids, and 1 PDL, and silicone gel. At least not uncomfortable, and we can go on to get even better results. Sternotomy scars were before when they did operations over the breastbone, more difficult and more tricky, but at least you can improve them and get rid of the symptoms. And this is a lot of keloids caused after tattoo away all over her back. And we have been trying to inject steroids. We have been trying to treat with non-ablative fractional. The symptoms, uncomfortable feelings, went away, but not the looks of it. So it's very sad. And actually, I have had 3 patients who received keloids after tattoo away. After hand surgery, can be very painful. So here we are treating with non-ablative fractional laser, 1550, to remove the tight feeling of the hand so the patient can move it and to get rid of the pain. Burns. At the hospital, we get a lot of severe burns. And if it's a severe burn and deep burn, it gets a lot of problem for the patients. You can at least improve it. And this is after CU2 that causes the burn, and PDL and IPL. And if you go on with more treatments than 3, you get even better results. Very often, if it's deeper burn, you get keloids that you need to treat many times. And here it is after fractional CO2, steroids, and the redness after CO2. So IPL would be good to reduce redness. This is the thigh after boiling water. Here, of course, you can use the fractional CO2 because it doesn't matter for the patient if they look like this for 5 days. And before, we combined it a lot with radiofrequency and CO2 to make it more smooth and easier to move the thigh and the skin and the joints. And here we have the combination of radio frequency and fractional CO2 on tight scar on the back of the hand after burn to give more flexibility. And they feel it almost when they go out of the door, that they can use the hand or the fingers better, because that's a scary feeling when it's so tight, the skin. Can be very painful sometimes for them. This is on the back. Painful and erythematous scars after burn. And cosmetically, it's not so impressive, but the feeling of it for the patient has improved a lot. The tight feeling. So sometimes we use ordinary EMLA, lidocaine, or we do a mixture with lidocaine and tetracaine, and that works very quickly. And afterwards, if it's been too tough, we use a group 4 steroid and contact cooling and compression, and we call them if they are worried. But I don't want to cool it down. I want the effect to start. So it's only if it has been too much. Pigmented scar. Pigmented skin has a higher risk of developing hypertrophic and keloid scars. For Hispanics, African Americans, and Asians, keloids develop in up to 6 to 16%. That's quite a lot. So I consider fractional non-ablative lasers safe and effective treatment options for acne scars in skin type 4 to 6. And here you have a lot of different articles who confirm that. We all know that on darker skin types, we have to try to avoid PIH, post-inflammatory hyperpigmentation. Use then longer wavelengths, radio frequency, and lower energy, longer pulses, and less coverage. But non-ablative fractional laser, usually very safe for darker skin type. And treatment density is a stronger factor than energy in determining PIH development. And it has been discussing, I think, at least for 10, 15 years, whether we should use bleaching creams or creams that reduces melanin production, like thiamdiol from Beiersdorf, or sunscreen factors before, during, and after treatment. And I think that's, I am using that and ask the patients to do that. And I have less PIH, especially if you treat with ablative systems. Hidradenitis. We have been treating for many years with CO2, but actually as a prevention, we are treating with intensifying slice hair removal, and that has improved the scar after all the 8 treatments. Inform the patients. Time will improve your scars, no matter what. It will be improved. And give them realistic expectation. It will not be as before. And they need multiple treatments. And if they don't accept this, don't start. And we know it's a risky area, upper lip, sternum, and musculus deltoideus. So prevention there, with PDL, for example. Congenital melanocytic nevi. Oh, that's big trouble, and we knew it, but we had to do it. And we got keloids, and we have to treat and retreat, ongoing story. And post-inflammatory hyperpigmentation, and also pigment coming back from the nevus. So combine wavelengths and techniques. Also, tight scarring after mama cancer operation and radiation. It can be improved. This is after 2 IPL, YAG, and a much better movement for the lady and more comfortable to have a bra. And scarring causing uncomfortable, tight feeling, especially on the neck. This is after a burn. And you can't use it as tough on the neck as on other places, but it's possible to do still the same combinations, and it gets softer. It's a higher risk of worsening on the neck, so be careful. Do regular treatments. Do not treat too tough and lower energy. We are also treating autoimmune diseases and scarring after that. This is after discoid, lupus, erythematosus, after CO2 and radiofrequency, some improvement. We did a study with microstomia, systemic scleroderma. It really relaxes the tissue around the mouth so they can open it better. So it's highly recommended to do that. So combine all these treatments, and we will hear much more in detail from our more experienced speakers today. So in conclusion, know your system, know your EBD physics all the time. Repeat if you forget, and keep your eyes and mind open, and you will find new and better ways to help your patients. And then you can prevent scarring and mix and match your lasers, IPLs, and topical adjunctive treatments as well. And improved understanding of fibroblast lineage-specific mechanism and how they determine scar severity will ultimately allow for the development of anti-scarring therapies and the promotion of tissue regeneration. So the main thing, give them hope. Patients are usually in lots of pain. Be there for them and always give them hope. It will get better. And medicine is a science of uncertainty and an art of probability. So this was my ideas and talks. It was a little bit of everything. And now we will go into a little bit more detail. And the next speaker will be Hugh Kachi. Are you there, Hugh?
Yes, I listen to you. Seems a lot. Okay, thanks really for this intro. Very large and long and strong experience, a very, very famous experience, very interesting, but it's too short, you know. To summarize more than 20 years of experience in 30 minutes, it's not so bad. Bravo. Bravo.
Thank you.
Okay. a lot of data, and we can discuss a lot for many, but we know how it's too difficult to discuss about scar because we have different point of view, we have different device in the world, and the most difficult is to know the good timing, the good tempo. Probably is most difficult. So let me introduce, I'm a dermatologist, and just to show you a very practical clinical data. Just a small introduction of my baby in Prima, because as you have used knowledge on other device, and we bought this Prima 2 years ago, and it was my third PDL, and the last one is good device, you know, because you have more strong efficiency. So I believe that, I don't know if you have the sound or not, or I speak about, but do you listen me or listen your video? I don't know. Is okay?
Yeah.
No. You have to speak or use video. We have the two possibilities, but just to show you how it is work, because it's very intuitive. You know, you have a touch screen. You can modulate the spot size on the handpiece. So it's so easy to modify the time. All is included, you know. The first V-beam, it was not easy, but you have to have your setting in your mind. But now it's easy to change the setting, to change the pulse, to change the energy, to change the time, the DCD. You know, it's very important to change that, because sometimes we forgot to speak about DCD, you know, to reduce the thermal effect. So sometimes we have to use for scar, for warts, for cuprosis, we have to modify the system DCD, but so easy to use. And you know, you have to summarize what you are doing. You have a short to start very quick, but you can include many things. So now this new device facilitate the use of this new PDL, and the good news that you have included in this device, the two wavelengths, PDL 595 and 1064 NDR long pulse, not for depilation, but you can use it. We use it, works, okay, but you have Gentlemax Pro for that. But for NDR long pulse, it works very well for vessel on legs, for big vessel on face, for venous lake on lips, on so many things, maybe a periorbital venous, so it's easy to use. And with to change and to move from 1064 to PDL is very easy. So now it's easy, it takes nothing to change the wavelength, and it's very, very used. And we have now in my clinic a new practitioner, and it is easier for a young patient to start with PDL, because a long time ago it was not so easy. And just to introduce the first case, it's very simple case, if it works. Yes. You know, it was this year, March, okay, and a young daughter of a good friend is plastic surgeon. Imagine when you have a good friend is plastic surgeon, and he sent his daughter just to remove a small stellar angioma. Nothing. It's very easy to use. You said, oh, I take my Prima, I shoot, and that's it. It's free. Or it takes maybe 3 milliseconds, you know, so fast. And it's interesting for me because this very simple clinic cases to discuss it just after that. It was in March, and she put his mask to protect from COVID, you know, and we has this the elastic with the mask. She had maybe it was my fault because my setting was maybe too high, but also with the mask she will have that. The day after, you know, see the crust, the purple reaction, it is normal because we have 3 milliseconds, 10 joules. And what's happened? And you see, and when you look at, you are so disappointed because you are a little anxious. Your patient, you know, it's a friend, and you have the daughter. It's a beautiful girl, and you say, "What?" And she said, "Oh, I have to join my father. He's in Dubai, and you live in north of France with no sun, you know." And she went to visit his father in Dubai, where you have a lot of sun. So you see that, you say crust, scar, pigmentation, what you have to do. But you are lucky. You protect with fusidine, with Vaseline ointment, on day 12, on day, it's inverse, sorry, but you know, the day 12 is the red one on the right, on month 3 is the other one with the light hyperpigmentation. What we can say, it is really that I put some fusidine cream or ointment, which it protect? No. I'm very lucky because I use a PDL, and it's very important to introduce that you can use PDL, and it's very rare to induce scar when you use PDL. When you use other laser, sometimes it could be worse. But with PDL, it's very rare. It's very safe to use PDL. So don't be afraid. Just an example. Another example, you know. After that, you say, oh, Dr. Cartier can't use any laser. Okay, it's terrible. Just this woman, she has a rosacea. She takes tablets, cycline antibiotics since many. She put a lot of cream, nothing worked. And I treated with my PDL. And she sent me a picture like that. You said, wow, certainly I will have some scar. Certainly, what can I do? And I was unlucky because his husband was a big man, a tall man, okay, more than 135 kilos, you know, okay. And he said, what you did to my wife, okay, I was a little anxious, you know. It was not really a funny situation, but I was lucky because I make a test on the arm of the husband because he was there when I treat his woman. And nothing happened on his arm. So he said, I have no reaction. If I had a reaction on his arm, probably I was dead today. But because that, I saved my face, and I said to my patient, okay, we have to manage. But it's not so easy when you see that. What I do very simple thing. I said, first, it's a PDL. Sometimes it's an incredible situation, but you see day 2, day 3, day 4, okay, what we manage. And I'm lucky because first I put LEDs, and I put LEDs device at home. I give my device, and I don't know if it works, but I have to do something. So I put my device at home, and she put on his face under red LEDs, 40 minutes, twice a day, more than 35 joules. I put fusidine ointment, and I give some anti-inflammatory to reduce edema. And after that, after 10 days, you resolve completely this bad situation. So I know that I use too high energy. Maybe it was my fault. Probably now I reduce, but I forgot something. You know, this patient, my colleagues give to this patient to reduce the rosacea low dose of isotretinoin, you know, Roacutan. And I forgot that. So too high frequencies, bad day for me, low dose of the trend, and it was the situation. But because we use PDL, and I insist on that, is very a safe device. Even you can expect, okay, maybe no problem, but you have to be aware, okay, about that. But really, it's a safe device to use, and it's a reason we can use this for scar or for burn scar very safely, and I will show you now. First case is, it's a young woman, less than 25 years old. She had a very slight scar, acne scar. And she visited her colleagues, and he applied peelings, glycolic peelings. But she was upset because it doesn't work. We know that because peelings, glycolic acid, it works for complexion, but for scar or ice peak, it doesn't work. So you need to use deeper peelings. So he said, don't worry, to this patient. He said, I will use now a roller, microneedling, and he put after the microneedling, he put TCA with slight solution of phenol. What happened? You create small hole and you penetrate directly with the TCA and phenol, and we know that bad news for the patient, you induce a scar. And she will visit me 3 months after with a start of hypertrophic scar, and I treat her, you know, you see the time to follow, to treat and to reduce the inflammation to the venue of the hypertrophic scar, and I combine the both, the PDL with low dose, 6 milliseconds, the superproving reactions you see on the lower slide pictures, DCD 2020, and I combine every 6 weeks with Frax to reduce the fibrosis. You will see on dermoscopy, you see the bridge of the fibrous tissue. And we know that you have to reduce the inflammation, to reduce the vascular disorder in the hypertrophic scar, and to prevent maybe keloid if you have the genetic predisposition to have keloids. And I combine with the both to flatten the skin to reduce inflammation. And it works. And I use the Frax from Norlis, you know, see my settings, and you see after a few months, it comes better and better. We know that it was a difficult case because the risk was hypochromic, and we obtained hypochromic. It's because it was a deep pills, increasing by the microneedling, though it was a mistake, an error, okay? So now they have some trouble, my colleagues have some trouble with the judge and the avocado because it was wrong procedures, okay? But now we stabilize the scar to reduce that. So you can combine, and it's very important that Anita said that you can combine the both. We have not only one device works for all, but you have to combine, and the most difficult is to start when you want to start a PDL, when you want to start a fraction, when you want to start CO2, Kenacort, 5-FU, toxin, LEDs, IPL is most difficult. For Anita, it's very easy because she knows and she uses this tool. Okay, she has many tools in his office, and she takes on Monday that one. But no, in his brain, she knows why she has to use that. And when you are a young practitioner, it's not so easy when you have to start on this device. But we know that now we have a lot of data. So if you combine a non-ablative fractional laser on PDL, you have no risk to obtain a worse result. So don't be afraid. You can combine the both. It's difficult to use the both in the same session, but some colleagues use, but I prefer to wait for weeks between each device to 6 weeks, and to change, and to move, and to reduce. And I change from the device, or sometimes I insist more with PDL, sometimes I come back to my fractional, non-abrasive fractional laser, and you reduce, it's the other phase, it's the other phase, you know, and you will see the result. Progressively, you see the return to stabilize, and you will see it's the same patient. It's not a it's a mycostomy. It's not after sclerodermy, but exactly the same. And you can, when you combine the both, you give more elasticity, more plasticity. You reduce the fibrosis. You give some relaxing skin, and she can open the mouth normally. So it's very important to use. So the third case. And was the settings, by example, for my fracs, and you see the result after, and we do dermoscopy, and we see the changing of the structure of the skin tissue after that, and we see the result after that. Second case, very common. You have a patient, she has a traumatic scar, okay, after training for a race on bicycle, and she have a very fresh traumatic scar. What I do, okay, less than 3 months, I use my Norlis 40 millijoules, and I inject inside to avoid the invagination of the scar. To elevate the scar, I put a hyaluronic acid in situ below and just inside to elevate, and I do in the same time than fracs, and you will see 2 months after, you elevate and you avoid the movement down of the scar. Is very important. You can also add some toxin to stabilize and to relax the frontal muscle. Sometimes it's very important for the upper face to use and to combine, if you have young scar, to stabilize and to stop the movement of the muscle. So we can combine also, but you see the result very simple. You adjust 1 or 2 sessions of fracs, and only 1 session of hyaluronic acid. For Asiatic scar, the skin is so difficult to use, you know, but with Norlis it's easy. The risk to induce hyperpigmentation is very low, and I use for this patient only fracs, and you will see the results. 4 years, 5 years. I started. He was 16, and now he's 21. And I treat this patient every 6 weeks, and after every 3 months. And we see the result just after the redness, the slight edema, and we see the result after a few, and we have a long-term effect, you know, 2 years after, you see the result, it works, but it takes time. If I used CO2 laser, it works more faster, but after that, we have to manage the pigmentation, the risk of hypochromic skin. So with fracs, you have to take your time. You explain to the patient it will take between 3 months, 6 months, but maybe until 15 months, but it works. But the tempo of each patient is different to another patient, but it works, and you reduce, and you flat the skin, you reduce hypertrophic scar, hypotrophic scar, and some hypertrophic scar also. So, and for Asiatic skin, no risk until to use fractional. For very dark skin, you know, I was very surprised to use my fractional non-abrasive laser, you know. You see, and I combine with hyaluronic acid to elevate the scar, you see, and it's very easy to use on dark skin. So it's very safe to use 1550 for dark skin. It takes time. You have to explain to the patient that it needs maybe few session, but and you help to elevate this hypertrophic scar with some drops. And I prefer, because when I use alone hyaluronic acid, the follow-up is low, you know, it's come again. If you induce in the inflammation inducing by fractional, and I treat immediately after or in the 10 days after the fraction, for me, we have a better long-lasting effect of the elevation by hyaluronic acid. So it's very important to combine the both. But we can also use hyaluronic acid after CO2, after the crossed healing time. After PDL also we use after many other lasers, but for fractional it's more easy to use just after. You have to see with your eyes where is the problematic, because it's necessary to inject just below the scar or inside the scar, but it's easy for even for you have dark skin. I will see some video of this patient. I don't know if it works. Okay, but so easy to use this device, very in good hand, but okay, it doesn't work, but it's not really important. It's very easy to use. Okay, I try to use the next. Okay, we will see. Okay, takes time. So you have to take time for scar. It's a little painful. You have some pulse, air pulse, you know, but sometimes I use my Zimmer just close from this from my own piece. If I want to add more, I prefer sometimes not to use anesthesia cream, because you know, the water in the cream can modify the penetration of the skin. So sometimes just air, cooling air is enough. But I take time, it's very low. But if you go too fast, the NP said you have to reduce the speed of your movement. For dark skin, for the skin phototype 4, you know, I use a fraction, my fracs, same setting around 40 millijoule, and I use some drops of hyaluronic acid just to elevate in the same time, and you will see the result with a good result for the laceration after the scar of the face. So very easy to combine the both, even you have this dark skin. For hypertrophic, you have to use we can use Prima, exactly the same, but I like to use also my IPL, because I'm very comfortable with this device since many years, and we use some drops of Kenacort or Kenalog, triamcinolone, and after that I modulate and I introduce my fractional for IPL, because sometimes you have to you induce hypertrophic scar, and I start with IPL or Prima, and after that I use on TAC, and after that I use a fractional non-ablative laser, and I combine with some hyaluronic acid just to elevate and to finish the job, and we see the result with a long-term, very long-term result. For scar, but it's not scar, it's striae, you know, it's easier to reduce. You can reduce the color of the scar. For stretch mark of the back, or for Jung, it was 15. And I use my Prima. I induce between just a purpuric reaction, 6 milliseconds, 8 joules, and easy to reduce. And I combine, when I'm bleaching the skin, I combine with the fracs to elevate, because we know that we have a hypertrophic stretch mark, and we see the result. You reduce. It can disappear, but you can reduce and maybe stabilize to avoid the enlargement. You know, the size of the stretch mark. I believe I try to persuade patients that if they do now, they reduce the size of the stretch mark with the combination with the both. You stabilize the size of the stretch mark, not the number of the stretch mark, because it could happen new, but you stabilize and finish. And it's very important to explain that you have to start now. When it's red, it's okay. When it's white, it's very difficult to reduce a stretch mark. Another clinical cases for stretch mark, you know, when it's black, is more blacker. You have sometimes some stretch marks are hyperpigmented, so it's very easy, and you combine. Not Prima, but you can combine the both yellow filter or orange filter 550, and combine the both to reduce, to modulate the structure and the texture and the complexion and the tone of the stretch mark, and you have a beautiful result after maybe between 3 to 5 sessions. It's very easy to use without any risk. Very important. And my last clinical cases is terrible clinical cases, you know, because I do phenol pills since many years, and sometimes you are unlucky. I was 40, now I'm 56, but I was 40. It's the day after my birthday, you know, you are very happy because you do what you are doing, it works. And I do a peel, full face with a peeling of phenol pills, and at the end of the day, patient called me, his husband called me and said, is it normal to have this phase just 8 hours after phenol pills? And I wait, receive this picture, I say, wow, we have something wrong. And I did peelings every week, you know, what happened. And you see, I learned a lot. It was more than 15 years ago. I learned to use PDA, LEDs, toxin, Kenacort on corticoid, drug delivery, CO2 laser on this patient, because I saw every day, every 2 days, every weeks, and during 2 years, it was terrible. But patient, I totally agree, and she follow me, but we give some advice, but nobody sees that because it's very rare to have a full face scar after phenol peel, because it's very rare. And you will see you have to manage that. So I put some mimosa powder to say, what can I do? I put some on morphine. I put on corticoid tablets. I give some antibiotic. I continue to antibiotic on antivirus tablets. And I try to manage, you see, the healing time. You see also the hypertrophy scars, and after that, the keloid scar. And you will see the face, so you have to manage, and it's not so easy. And you learn how to use, you know, PDL. You will see below the last slide how to use PDL, and it's not so easy to explain to your patient that you can use laser on this face, because you are a little afraid. When you ask your patient or your colleagues around you, they said you are completely silly to use a PDL on this scar. It was 15 years ago, so it was not so easy to manage patient, to collect, to have some question to my colleagues. When you ask some plastic surgeon, say, oh, I can't help you, it's your problem. So it was not so easy, but we have good friends in the world to explain how to manage this different tempo, and it was not so easy to manage. And she put on his face during 18 months a silicone on personal and specific mask of silicone, you know, all during the day, to stop, to manage, and to manage the mycostromia, to the opening. So it was very difficult to use, and you will see the result before, 2 years after, and now 13 years after. So it was a good, and at each time I use my Prima, my PDL, I know that now I can use in many situations, and it's a very, very safe device to use in many, many situations. It's very important to know that maybe it's the most easier to use for any practitioner or for young practitioner, even you are in bad situation. Thanks a lot.
Thank you very much, Hugh. And thank you mainly for sharing your side effects that we all have and that we all are scared of, and we need to take care of them, but we all have the side effects and we need to know the tools how to handle it, which you did great. I actually have some more questions to you, but I think maybe we should wait till after everyone has spoken. But thank you, Hugh. Excellent talk. And now, Andrei Martin, plastic surgeon from Romania, will share with us his experience. So please, go ahead.
Okay. Thank you. Great lectures from both of you. Every time I have to prepare a presentation, to speak, to teach, I have a very, I'm learning, you know, so great.
Me too.
Presentations from both of you.
Thank you.
Thank you for giving me this opportunity. So scar management is a hot topic for a few years now. We've made significant progress in understanding the physiopathology of scarring, mediators, factors involved in this process. We can now modulate or mitigate the abnormal scarring. An international panel of 26 dermatologists and plastic surgeons from 13 different countries and a variety of practice backgrounds was self-assembled to develop a consensus recommendation for the laser treatment of traumatic scars. The conclusion of this panel was that lasers are the first line therapy in the management of traumatic scars and contractures also, and patients without access to these treatments may not be receiving the best available care of injury. I think we should go further implementing the standard of care for scar treatment, because it is obvious that more resources are needed beside conventional treatments, let's say massage, compression garments, silicone sheathing, steroid injections, and surgery. And lasers and EBD devices are actually replaced. So my lecture today will be about picowave device, the picosecond laser from Candela, and its application in scar management, exemplified by some clinical cases. I will present how we integrate the picowave system as a multi-device approach together with the V-beam and the CO2 fractional lasers. Picosecond. Since 2012, picosecond lasers have been FDA approved for laser tattoo removal and the treatment of benign pigmented lesions. However, the applications of picosecond laser continue to expand beyond exogenous and endogenous pigment removal to acne scarring, photoaging, and more. Why we need picoseconds? If we are thinking at laser tissue interaction, the time, how long the laser beam, the time on tissue, the pulse duration is essential in this process. One really short time, 1,000 nanoseconds or 1 trillionth in a second. And this means that we can deliver high peak power in a very, very ultra short pulse duration. So we get more a photoacoustic effect than a photothermal one, with less heat, more mechanical effect, fewer side effects, with more tolerable treatment for our patients and less recovery time. Picowave system has 4 important features. First one, it has 4 wavelengths, 1064 nanometers NDI laser, a double frequency 532 nanometers, 730 and 785 nanometers titanium sapphire laser pump laser. The second, which I think maybe is the pulse duration. It is a true picosecond pulse duration. 50 picoseconds for the Zoom 330 nanometers handpiece to 470 picoseconds for the Zoom 1064 nanometers handpiece. So this is actually a true picosecond domain. The fourth one, the third one is we have the adjustable spot size and fluencies, all the lasers has. But the fourth one, and I think another important one, is that we can deliver the energy, the incident beam, as a full beam with the Zoom handpiece. And also we can deliver it fractionated in on handpieces 1064, 532 nanometers. And now 532 fusion handpiece for better treatment of pigmented lesions. So the applications of the picowave, it was, as I said, initially administered for the treatment of tattoos, are regularly employed for the treatment of uneven pigmentation, acne scars, wrinkles. For scars, it's obvious that we are targeting the skin texture, specifically the atrophic scars and the hyperpigmentation. As I said before, picowave system has 2 ways of beam delivery: the Zoom handpiece, the full beam, for which the laser tissue interaction mechanism is photoacoustic one instead of the photothermal one. We can deliver high energy extremely rapidly. Sorry. extremely rapidly, causing the chromophore target to shatter due to mechanical stress, like chromophores, like for tattoo removal, pigment lesions, and even for picotoning. The option is the split beam, the fractionated beam, in which the incident beam is delivered fractionatedly in 100 identical microbeams, uniformly spaced to assure maximum uniformity with the resolved handpiece for 1064 and 532 nanometers. Regarding the laser tissue interaction, this is a different story on which I'll talk a little bit later. So another unique feature of the PICO-A system is the new generation of array with a 6 times 6 millimeters using the holographic beam splitter technology. As you can see on the slide, after shooting on laser line paper, on Zepid paper, the holographic fractional technology offers the same amount of energy for each spot, which is in a clear reflection regarding the precision and the efficiency of the treatment. So PICO-A resolved both 1064 and 532 nanometers, deliver the pixelated pattern of 100 microbeams, uniformly spaced to assure a maximum treatment uniformity, and creating, this is the main important thing which we are getting with the PICO-A system, creating subsurface lesions to stimulate collagen generation and skin remodeling. So we will get a lower downtime because we are not interrupting the skin barrier, and with a lower risk of infection. Regarding the histology, we have these histological changes after PICO-A resolved treatment with both handpieces. We have this publication released on January 2020, which concluded that superficial intraepithelial LAOBs, laser-induced optical breakdown, was seen in skin treated with higher laser energies. Deep intradermal laser-induced cavities were seen in skin treated at lower energies, and the lesions were spaced in 600 microns intervals, or its multiple, which is obvious done by the laser. And the lesion size that were consistent with the previous reported values. So here we are. I choose these images which are more than suggestive for epidermal and dermal lesions induced by PICO lasers. Picosecond laser pulses have been shown to provide sufficient peak power for generating laser-induced optical breakdown in the epidermis and laser-induced cavitation in the dermis. Laser-induced optical breakdown or laser-induced cavitation is a laser matter interaction mechanism, a process that results in cavitation bubbles in the skin, which have been suggested to expand, disrupt tissue, and generate shock waves to further disrupt tissue and generate repair. So I took this picture from Dr. Shoemaker, present the mechanism of rejuvenation for PICO-A with the PICO-A resolve 1064 and 532 nanometers, and you can see obviously in the right panel at hematoxylineous stain section of we can see the vacuoles of 0.2 millimeter diameter in the upper dermis caused by laser-induced optical breakdown. The tissue section was taken immediately after laser irradiation. And on the right side, the tissue section stained with Herwig stain, which is a stain specific for collagen, in which we can show the new collagen formation from healing to from the LAOB damage. This sample was biopsied 30 days after laser irradiation. So there's a increased ratio of collagen type 3, which is stained in blue. It's evident here. We can address different scarce features like dimension, color, texture, pain, sensation, using specific laser resources like ablative fractional laser, non-ablative fractional laser, dye laser, pico, excimer system, which was presented before, very comprehensive by Professor Joyce. Regarding the pico-way treatment of acne scars, I think that for pico-way system makes sense treating the rolling, the mild acne scars, rolling atrophic scars, and the post-inflammatory hyperpigmentation. So we have here two studies, one released in 2017, and the other one last year in January. Both of them that after treatment of acne scarring, mild acne scarring with a dual wavelength picosecond domain laser, incorporating a new holographic beam splitter, which is the pico-way system resolved, we have a significant improvement which was accompanied with a very high patient satisfaction. We had low and mild transient erythema and edema, so we have low adverse effects, and there are no complications like hyper or hyperpigmentation or scarring. So here's, I'll jump to case studies, clinical presentations. So here's a patient before and after 4 sessions of pico-way resolved 1064 nanometers at 1 month each other. This is the on the other side. So this patient was included in a study conducted by my colleague Larissa Nistor, which is a dermatologist. She assessed this study with this Antera 3D camera, which provides volumetric measurements suitable for atrophic, hypertrophic scars, the dermal fillers, injections, and it provides a full set of features including wrinkles, texture, pigmentation, redness, and also it includes an additional tool for analysis. So here we have the Antera 3D camera report. There's a significant improvement in depressions less than 1 millimeter, also for the depression less than 2 millimeters, and improvement in pore size. I think here is a mistake. Actually, this is how the patient looks immediately after the treatment in day 0. It is quite impressive redness and redness, erythema, and edema, but it fades within few hours or few days. As you can see here in day 3, it's almost completely clear. Another case with a childhood burn with a post-inflammatory hyperpigmentation. We tried first to solve this problem using the fractional CO2. We did a session with the fractional CO2, laser. We get some kind of textural changes, but the pigment is still there. After we get the pico-way system, we moved to the one session of pico-way 1064 nanometers with 2 handpieces, 6 millimeter, 1.5 joules per centimeter square. At 2 days, it's a little bit red, but after 1 month, it is completely clear. Another case, a patient 6 months post chemical burn, combined with a thermal burn, with erythematous and hypertrophic scar. The treatment plan is to reduce the inflammation and the pigment to get the textural changes, both from the scar on the dorsum of the hand and on the ankle. We plan to use the V-beam to reduce the pigment and inflammation, and to get some textural changes using the core and the pigment with the PICO system. So here it is, the patient before and after one single session of V-beam Prima, 7 millimeter 8 joules, 1.5 milliseconds, 320. On the hand, we started with the core, the deep mode, 5% coverage, 60 millijoules, and we apply triamcinolone 40 as a laser-assisted drug delivery. Here is before and after first session. So we saw that we also have some kind of hypopigmented areas. So we tried to repigment this using the Lumigan 0.1 millimeter. We did it like a laser-assisted drug delivery with the core system, 4% coverage with 30 millijoules, so low energy, and the scar was treated 5% coverage, 60 millijoules plus triamcinolone. So here are the results before and after. And then we decided to get rid of hyperpigmentation, and we did 3 passes of PICO resolve, 1064, 1.9 millijoules 3 passes, and 7032 nanometers, 0.4 millijoules with 1 pass. So we started from here with this thick hypertrophic scar on the dorsum of the hand, and we get here after 3 sessions of core, in which 2 was laser-assisted drug delivery with TCA and Lumigan, and 3 sessions of PICO resolve with both 1064 and 532 nanometers. For the leg, as we know, the lower extremities are prone to hyperpigmentation, post-inflammatory hyperpigmentation. We wasn't so successful with the core deep and the triamcinolone as laser-assisted drug delivery. So we moved to the PICO way and did 3 sessions of PICO resolve 1064, 1.9 millijoules 3 passes, and 532 nanometers, 0.5 millijoules 1 pass. I think this is a quite acceptable result. Burn scars. This is a patient with a childhood burn, with hypertrophic scar, with post-burn alopecia and post-inflammatory hyperpigmentation. The treatment plan was to restore the hair and the eyebrows, to get some textural changes, and to reduce the pigment. We did the FUE hair implant. We did the core fractional and the PICO for pigmentation. Here it is. As you know, there are some kind of hyperpigmentations which are very, very common in burn patients. Some kind of hyperpigmentations like this one, which can be treated easier with a PICO system, 1064 zoom handpiece, 6 millimeters, 1.5 joules per centimeter square. This is how we get the frosting effect, and this is the picture is taken 1 month after. On the other side, same lesions, treated with a PICO 1064 zoom handpiece, 7 millimeter spot, 1.5 joules per centimeter at 1 month. Another burn scar 15 years for thermal bone scar with mixed aspect, hyper and atrophic, hyper and hypopigmented, with the erythematous plaque on the right cheek, and with the lid retraction and the contraction, which was limiting the opening of the mouth. The treatment plan was to reduce the erythema, to reduce the pigment, to get the textural changes. We used the Vivin dye laser, the core ablative laser. We used the laser-assisted drug delivery of triamcinolone 40 for the hypertrophic portion of the pico way for the atrophic part of the scar. So here it is, after 8 pulse-dilate treatments and 10 core ablative fractional laser, from which 2 were laser-assisted drug delivery, TCA laser-assisted drug delivery, which deep 5% coverage at 6 to 8 weeks. On the other side, the same regime. So here we're supposed to have it work. Okay, it worked. So here the picture before and after. It is very important when you are taking the choice. It is very perpendicular to the skin, and if you should keep it perpendicular and attached to the skin. We are doing 2, 3, or even 4 passes. We are moving to this is before and after. Important thing for this patient is that we reduce the contractor, we soften the scar around the mouth, and there is no limitation in opening of the mouth. Here, as you can see here, there's a significant improvement in mouth effect. This is the treatment of the mouth surgery. We do some kind of water step and the reception step. We came with the red and hypertrophic scar. Our plan was to reduce inflammation, to get some structural changes, and we are planning to use the fractional CO2 with the laser-assisted drug delivery of triamcinolone, and the V-beam laser for the erythematous component. So we did 5 sessions of dye laser, 7.5 joules, 1 millisecond, 30/10 BCD, and we did also 5 sessions of core, from which 2 were with laser-assisted drug delivery, triamcinolone, with the deep, with 5% coverage, 50 to 30 millijoules at 6 to 8 weeks. So this is from the other side, and the frontal view. I think this is a quite good improvement of the scar, and the patient is very happy with this. Another patient, a dog bite injury. I saw this patient immediately after the injury. We sutured the wound, and we tried to modulate the scar to get some textural changes, and finally we did some pick away for the pigmentation. We start the V-beam treatment earlier, immediately after removing the sutures. We did almost 10 the sessions of V-beam with 5 mm spot, 6 to 8 joules, 1.5 millisecond, 30 to 10 dCDs, until we get on this aspect. Then we moved to the CO2 fractional laser, and we did 4 core deep 5% coverage with the 50 millijoules until aspect, and then we moved to pico wave, which is very well tolerated by the patient. We did 8 sessions of pico wave resolve, 1064 nanometers with 1.7 millijoules, 3 passes at 3 hertz. And we got that result. So we started with the V-beam, continuing with the core deep 5% confidence of the pico wave resolve 1064. Thank you very much for your attention.
Thank you very much, Andrei.
To Barco.
Thank you very much, Andrei. Very interesting, and I don't have a Pico machine, so it was quite interesting to hear about your experience and good results. And we will keep the questions till afterwards. And now, Dr. Didac Barco from Barcelona, we are looking forward to hear your results after treatment of scarring. Please go ahead.
Thank you, Agneta, for the introduction, and thanks to Candela for allowing me to speak today. My speak will be about the core system in the treatment of a scarring. If we take into account the 2020 international consensus recommendations regarding the treatment of scars, it is said the CO2 laser, it is said to be a groundbreaking treatment, and it's because of its versatility, because we can use it either in the atrophic scars or in hypertrophic or keloid scars, right? So we can use this device for any type of scarring. So that's why it is a mainstream in the treatment of scars. Yes, it's a very useful tool, but it's not a wonder. You have to take into account some things. For example, we have to be very careful to use high energies or high densities in proliferative keloids, because the heat of the laser may stimulate the overgrowth of these fibroblasts. And it is also said to be the energy-based device that has more side effects, hyperpigmentation and redness for some time. So that's why we have to take into account these issues with the CO2 laser. If we take a look at the publications regarding CO2 laser and acne scarring, it is said to be the best option to treat this type of scarring, to address this type of scarring. This is the technique that we tend to use in our clinic, because the classic CO2 laser is the gold standard that causes the maximum efficient result. We tend to use a classic resurfacing in the most severe scars using a pinpoint technique that we're going to show right now in a video. We use the core with a classic resurfacing mode in 2 millimeters spot at 3 millijoules, and then we zap at every bad scar that we have, the worst ones. After this, in the same session, we move to the fractional aggressive CO2 settings. We then use the fusion with a core of 80 millijoules, a ring 111 millijoules on top of the first pass, and all around this first pass where the also bad scars are, and all around this where the mild scarring is, we do a mild fractional CO2 settings. We go for the fusion using core 60, ring 90, or even mid mode at 100. So using this technique, we get to have the best efficiency in the worst areas, reducing the areas where we may have the worst side effects, and we tend to use safer settings where the lighter scars are, so we tend to save in terms of side effects. We're going to see a video right now of this technique. Can you please play it, Samantha, please? All right, so what we're going to see right now is how I use the classic resurfacing mode in each and every one of the ice pick and boxcar worst scars. So what we're doing is a classic resurfacing where we need the most efficient treatment, but we want to save side effects, so that's why we'll limit the treated area in this mode. I hope the video is going to be played. There we go. Are you seeing the video right now? Excellent. So this is the core system in the classic resurfacing mode. 3 millimeters, 3 millijoules. I'm just shooting at each and every one of the scars. This way I'm sanding the walls and the floor of each and every one of the scars, limiting my side effects in just these areas, but achieving the best results also in these areas that are most damaged. After this, we're going to the fusion mode, ring 111, core 70, for example. We can stack on what we've done before. We do a fractional resurfacing in the worst areas. And around this, I will normally also do a mid or lower fusion pass. All right, so this is the targetoid technique, and I think we've achieved the best results using this way the core system. So you see here a before picture. This is the after picture, 2 sessions of the core system using the targetoid resurfacing as stated before. This is the before. This is the after. Dramatic change in just 2 sessions. And although this patient is phototype 4, she had no side effects using this technique, right? So same technique here, using classic resurfacing in each and every one of the box scar and ice pick scars. After this, in the same session, fusion settings all over it and all around it. Just 1 session, 1 year. There's 1 year in between the before and the after picture. Another treatment of ice pick and box scar scarring using this technique, 2 sessions, 1 year spared each photo. All right, we've talked up until now about atrophic acne scarring. We now move forward to keloids and hypertrophic scars. We divide these scars into phases. The first one is proliferative, the one that means the scar has redness. The patient may feel itch and pain. The scar is growing. And the second phase is the steady phase. In this phase, the keloid is stable in terms of growth. It's normally not red, but skin color, and the treatment of each phase is different. In the proliferative phase, we do need to use vascular lasers to reduce angiogenesis. We may use vascular lasers or IPL, and we normally tend to use also injections of steroids and or 5-FU, or if you're cautious, you can also use CO2 and laser-assisted drug delivery. TRIM is in steady phase. We have to take a look at its location, if it's auricular or non-auricular. We're going to treat the steady keloids with the CO2 laser, but regarding their location, we will have different approaches. It's absolutely contraindicated to use high densities and high energy when treating keloids because the thermal insult, it may worsen the proliferation of fibroblasts. So we have to use different settings when using a fractional CO2 laser. The literature recommends us to use health settings, which means high energy and low density. We're not looking for coagulation and fibroblast stimulation, but we're going to look for ablation. So the drugs that we use for laser-assisted drug delivery can penetrate deeper. And it means we're going to use short pulse duration and thin beam. With the core system, it means the deep mode. Right, deep mode has 5% density. I normally use 70 millijoules energy to treat keloids. And if I think that the density is too low because the machine does not allow me to increase the density, I may increase it manually up to 10%. I just move the handpiece a little bit and then I shoot again. So I calculate, it's about 10% density setting. It's not only used for collagen remodeling, as I stated, but also for laser-assisted drug delivery. We're going to use the same settings, and we can use either of these drugs. We can see a video here that will be played right now. We're treating a burn scar. It's an old one, so it does not have any erythema. So this is why we're not using any vascular or IPL device. We're using the CO2 in deep mode, 5% density, 70% millijoules. I may overlap a little bit to increase the density. After this, we're going to use contact cryotherapy. It helps with the thickening of the scar. And last but not least, we're going to use the drugs, a mixture of 5-FU and of triamcinolone acetonide to do the LADD. Right? This is a complete burn scar treatment with a CO2 laser combined with cryotherapy and also laser-assisted drug delivery. We see here a before-after of a steady keloid on the chest in a girl. The arrows show two intradermal nevus just to help us to see the change of the keloid. This is after 3 sessions. We did exactly the same procedure as you have seen in the video, right? Just 3 sessions of contact cryotherapy. In this case, I did intralesional injection, and the last session was with the CO2 and with LADD with triamcinolone acetonide. All right, we have talked up until now about keloids not in the auricular region. And in the auricular region, in this area, this is the only location where surgery is said to be the first option in the treatment of keloids, right? You can do different surgical approaches, but one of the most popular is shaving the keloid with a CO2 laser, and immediately after this shave, you can use the cryotherapy, in this case in spray mode, and after this, you can do the injection with any of these 2 drugs. we're going to play a video right now regarding this procedure. We first apply local anesthesia with mepivacaine. Once it's completely numbed, we move to the surgical mode. We're using the lowest energy possible, which is 5 watts. We then cut the keloid, and on the bed of the wound, we do some hemostasia. And after this, we do liquid nitrogen in spray mode as a prevention for the keloid to come back again. And after this, we do the injection with a mixture of 5 FU 9 parts and 1 part of triamcinolone acetonide. We're going to see the patient every 3-4 weeks, and we will probably do a cryotherapy and injection in each of the controls. The patient should be followed at least for 6 months. Here you see some pictures of the before and after an auricular keloid treated exactly with the same technique you have seen in the video. You see after 15 days, the wound is still repairing itself, and after 3 months, you only can see erythema. So that would be my approach with the core system in atrophic and hypertrophic scars we see every day in our clinics. I hope it was helpful for you, and I will be here for any question you may have for me.
Thank you very much, Didac. I can really tell that you are a teacher at the university and masterclass in laser. You do it very didactic and excellent results. And now we can go. Thank you. And now we go on with the questions. I have a few questions. Maria, should I start with my questions to the speakers? Okay. May I do that? Okay, thank you. As it was closed now, Didac, I start with you.
Great.
Did I an excellent result? Did I understand you right regarding the acne scars? You had a dramatic after picture. Did you go first with your CO2 lesional and then the skin resurfacing? Yeah. Classical skin resurfacing. Did I understand you right?
The classical resurfacing was limited to each scar. After this, I made a fractional resurfacing on top of it, and all around this, I did a lighter fractional resurfacing too.
A lighter skin resurfacing around.
Yes. Yes. So we're using the same.
How many treatments did you do?
In this patient, we have seen just 2 treatments.
2 treatments. And
yes.
I think we all see good. Please?
Sorry. The gold standard for acne scarring is still today the classic CO2 laser but because it has so many side effects, I thought that limiting it to the worst areas would permit me to have high efficiency, but with low side effects, right? Because I'm just using it in a very small area. And in wider areas in the same patient, I then move to the fractional CO2 laser, which is also efficient, but it's going to have a much less side effects. So I'm combining a classical and a fractional CO2 resurfacing in the same patient to take advantage of each technique.
Excellent. And that's our recommendations, isn't it? That you should combine wavelengths and techniques according to what you have in your clinic and topical treatments. We have a question here from Christina Ona. Is there an optimum energy to treat white stria with the CO2 laser? optimum energy to treat white stria with the CO2?
I would use the deep mode, 5% density, 9 millimeters spot, and depending on the area, I would move between 50 and 70 millijoules. Remember then that when using the CO2 laser in the body, you may have persistent stamp scars because of the beams of the laser. So only use 70 millijoules in very thick areas of skin.
Thank you. And I will go on to, let's see. Dr. Martin, is there a certain reason to use as first-line non-ablative fractional laser in atrophic scars and not the fractional laser? This is a question to Dr. Martin.
Yes, I think the most important is to get a short recovery time. For those who choose the non-ablative fractional laser instead of fractional lasers, is the recovery time. Even the results are not the best, as Dr. Barkov said that this is the standard of care, the CO2 fractional for atrophic scars. We offer it to our patients with atrophic scars, and the main reason is the short recovery time.
I do agree. We also use first-line non-ablative fractional. And sometimes, another question, Martin? Sometimes after pulse-dye laser, even if the settings are subpurpuric, I observe a slight brown colorations. Is this a PIH or is it hemosiderin from the degradation process of the purpura?
It depends on what means subpurpuric brown, subpurpuric, because if it's subpurpuric, you don't have explosions of the vessel, so you don't have to have the hemosiderin deposit into the skin. So I think that it's about hyperpigmentation.
You think it's a PIH, post-inflammatory hyperpigmentation?
Yes.
Okay. How do you manage the acneiform reactions after pick away resolve? How do you manage the acneiform reactions after pick away resolve?
We didn't have so many acneiform reactions. Usually it fades by themselves in 2 days, 2 days, 2, 3 days. If we had pustules, for sure I'm a plastic surgeon, but I refer to a dermatologist in my clinic, and we can use the Duac gel and the benzoyl peroxide for 1 week, and it will fade away.
Oh, good, because many talks about this. Regarding, I think, the PDL, I think the purpura is actually hemosiderin that you have as a pigmentation, unless you have a darker skin type. And now we go to you.
Yes.
To you, I have questions here. Yes.
Only one.
Also
The ultimate question.
The ultimate. Why do you use hyaluronic acid and 1515? I mean, why? Tell us, why do you think that's necessary and how do you do it?
I take my hand, I take my glasses, I look at the scar, and for hypertrophic scar, I believe that because we use ionic acid in daily practice for every year, we use that. And, for hypertrophic scar or to stimulate, for hydration, ionic acid is a super polysaccharide for that, and without no risk, low risk. You know, the risk to induce embolism is very rare, and because in scar, I don't inject hyaluronic acid scar for nose, because we know that if you inject in a fibrotic tissue in this area, it could happen something wrong with an embolism or risk of necrosis tissue. But for all scar, I believe if you elevate the scar, you relax the scar. It's like like for the myomodulation, so the relaxing modulation of the scar. You put something below and you rest the scar. The first point is that. The second point is to inject, to project the scar. Because with time, we know that the scar will go down. So if we put a support to support the scar when she is in the healing time, you help to stay and to stabilize the bridge of the scar. And the third thing is to elevate inside and to elevate the skin tissue, because the fibrotic tissue reduce the depth and the thickness of the scar. If I induce inside, so very small drops, I stabilize and avoid the thickness, the reducing scar in time. And the last thing is for hydration. So I use different kind of hyaluronic acid to project, for hydratations, to stimulate or to stabilize. But my favorite is Nasha.
Yeah, okay. And you do it after the treatment?
Yes. Or? After. On the right choice with a good tempo. With a Norlis, I inject, if possible, just after the session, but very fast just after, because you have an edema. If you have too much edema, you can't see anything. So it's not so difficult. Right. If not, I can wait maybe 10 days and inject 10 days between 3 weeks. And I repeat, but if I repeat frax, I have to wait, because if you put hyaluronic acid just inside the scar, you destroy it and you can modify the structure. But if you inject below the scar, you have no risk, because the point of depth of the fraxel is no more than 1.2 millimeters. So no risk if you inject below. But if you have the same level, it's silly to combine the both. You know, you have to wait. Maybe I wait to stimulate maybe 3 months, 6 weeks to 3 months before I repeat a frax. Okay? For CO2, after CO2 laser, I wait 10 days to 3 weeks to inject inside the scar in the inflammation time. I don't wait too much, because if we go back to the stabilized scar, it's too late for me. But now most of my scar, maybe I use in 80% hyaluronic acid in each procedure on scar.
Thank you very much. Interesting. I never tried that. Good thinking. Okay, I have put together a few cases that I would like to share with you. Samantha, can you bring up my cases, please?
I would like just to add something. For the phenol peel, you know, I'm not a chemist. I bought the phenol, you know, and I bought to the industrial, but the formulation was wrong. Okay, it's very rare to have this kind of problem with the laser. It's a problem of the peelings. If the formulation is wrong, it could be very bad result, you know, on scar. So be aware with it. I do again peelings on phenol too, because it's super result, but it's very dangerous. Even we have maybe better result with phenol. We have to balance between the laser, CO2 laser, and phenol peels. So be aware with that. And please don't apply peels after micro needling. Before, why not? You put your peels and you make micro needling. But if you put your peels after the micro needling, it could be dangerous, because you have directly a hole to the deep dermis and you have obtained at each time scar. We have many cases in France because a lot of nurses or beauty center want to do that to increase the result, but at each time we have scar.
Thank you. Okay, now we have 6 minutes left, and I would like to ask you three your main message to the audience. So we start with Didac, Marco. You have each 1.5 minutes. 1 minute. What is your main message to the audience?
I have two messages. For recent scars, whatever they are, use vascular devices to regulate all the angiogenesis and the collagen production. And for all scars, if possible, use CO2 fractional laser, because I think it has better results than the non-ablative fractional laser, if you can afford that side effects associated to CO2 laser.
Thank you. And André, what do you say? André Martin, do you have your message, your whole message to the audience? What is that?
Yeah. My whole message will be that you don't to resolve the case if you don't have enough resources. You should refer the patient for which treatment is the best for him, and to get the best resources. Because that's why I think that we should introduce some kind of standard of care. You have to give the patient the best options for him.
Mm-hmm.
So if we are speaking the multi-device approach and multimodal approach, the surgery, the laser, the EBD devices, injections, and so on.
Yeah. Well, it's challenging, I think, to treat scarring, and it's possible to help them. And you, Katje, your home message to the audience, please.
The earlier you treat, the better it is. We know that now we can treat scar before the scar. With publication of Marie-Thérèse Dasdal, she treat patient before just biopsy. She treat with laser before we do the biopsy, and the better it was after if we compare to treat laser just after. It was very interesting. So we can inform the skin that more you intervene earlier, more you can expect results. So the key message to my plastic surgeons that don't wait and don't send patient at 1 year after the surgery. Is at each time too late. We can intervene maybe when we remove the threads. We combine CO2 and pulse dilators 10 days after the surgery. We can do that, no risk at all. When you look at the publication, you have no risk. And the second is to the patient, is for the patient, is never too late to propose laser.
Very good.
Many kinds of lasers.
That's right, and that was a very good ending. And then I would like to thank you all. I know you have done a lot of work just to find your pictures before and after, and to think through what you are doing and what you would like to share, and look into the latest literature. Thank you so much. I know you spend a lot of time instead of being out in the sunshine and enjoying yourself privately, and you all work hard. So thank you so much. And I would like to thank Maria and Samantha for your patience with us and for inviting us. And I wish Candela good luck. Thank you all.
Thank you.
And keep safe. And I hope to see you live soon at meetings and conferences. But keep safe.
Yes. See you at INCAS Congress.
Yes.
Bye-bye.
Yeah. Gladly you.
Bye.
Thank you all.
Merci.